thank you very much for having me. It's a real pleasure to be here. I'm going to talk to you about some of the medicines that we're now using in inflammatory bowel disease. I want to first of all say thank you, Angie, for setting the scene so beautifully. And although this is all about medicines, medicine is definitely not the only therapy for IBD. One of my very close colleagues is in the audience as a surgeon. You're going to hear from him later, Bruce George. Surgery is sometimes the first treatment in IBD. Sometimes it's medicine. Sometimes they come together. And we're all working as a team to make the patient as best as they can be. So this is a focus on medicines, but it's not meaning that medicines are the only answer. What will I be talking about today? If I can get that to work. I'm going to be talking a little bit about why we're using medical therapy, what we're trying to do. You can't really talk about medicines in IBD without understanding a little bit about the challenges of the immune system in the gut and how these treatments have developed. So there's going to be a little bit of immunology, but I'll lead you through it slowly. And then I'll talk, as per the remit, on what we have now and the really exciting fact that we've got lots of therapies that are coming along now. We're really living in a golden age of therapy development. So here's just a sort of typical MDT case, just to reflect on what often happens in IBD. Here's a 26-year-old woman. She comes to the IBD. She's got terminal ileal Crohn's disease, which means the end of her small bowel is affected. She's not tolerated azathioprine. She's not appropriate for methotrexate because she wants to have children. And she's been on one of our earliest therapies, adalimumab, which is anti-TNF, and she seemed to do well on that. But now she's got obstructive symptoms, which means that when she eats, she gets pain and she feels bloated and sometimes she'll vomit. And she's got slightly raised inflammatory markers. And here's her scan, and she's got a thickened, inflamed bit of bowel, and it's dilated above it because it's causing some obstruction. And unfortunately, she's also got an abnormal connection between the bowel. That's called a fistula. So that disease has progressed. And unfortunately, from a medical point of view, that's another one for the surgeon. So in a sense, we've failed to give her the right therapy to ensure that she doesn't progress to the point where she needs one of my surgical colleagues. Not that that's a failure overall, because actually it's a good therapy for localized ileal disease, but from a medical standpoint, things have progressed despite what we're doing. So what are we trying to do with medical therapy? We're trying to make sure that the patient feels better. That's goal number one. And that's kind of obvious to say, but actually it's not the same for all patients. Not all of our patients have symptoms. Sometimes the second aim is more important. They don't really have any symptoms, but they've got quite bad inflammation, and we need to prevent bowel damage. And that's what comes at the end there. We know that if inflammation progresses and is left unchecked, that even without much symptom, it can lead to problems. This is reflected in these sort of international guidance that's coming out. And what's happened here is that instead of, on the left, just aiming for symptomatic response with our medical therapies, we're now, on the right, aiming for quite serious outcomes, difficult outcomes, like full bowel healing. So the inflammation completely going away. And this has been a stepwise change through the years of what we're aiming to achieve based on the evidence that we have. You've seen this graph already, but this is why inflammation matters, because over time, if you don't control it, you accrue damage to the bowel. You get fistulas, which is you saw in that earlier case I showed you. You get strictures, and that inevitably leads to surgery and often recurrent operations. Is that the same for UC? Well, it's not quite the same. UC, thankfully, although you can get strictures, is less common to get strictures and bowel damage, but you do, from this nice work from St. Mark's, increase the risk of getting abnormal cells and cancer in the bowel if you don't control the inflammation in ulcerative colitis. So even without symptoms, there are other reasons why controlling inflammation with medicines is a good idea. So here's some basic immunological concepts. In essence, the immune system has a careful balance to maintain. It has to be ready to activate when it sees a pathogen, a virus, a bacteria, and destroy that, but it doesn't want to damage and inflame normal tissue. So it's constantly in balance. And there are lots and lots of mechanisms that have been described that are pro-inflammatory and anti-inflammatory that maintain that balance. If there is a bug that comes along, then the pro-inflammatory arm will activate, and that will lead, hopefully, to killing of that bug. And then the restitution comes, the anti-inflammatory mechanisms will kick in, and you'll get the balance reformed. This can go wrong. In inflammatory bowel disease, those restitutive mechanisms never kick in properly, and you get persistent inflammation. It can also go wrong the other way. You can get persistent infection or indeed cancer if the other mechanisms are overactive. And this is really important, not for today's talk, but understanding this is the basis of all of that new immunotherapy that cancer patients get for melanoma and renal cell cancer and so on and so forth. Understanding how to undo the anti-inflammatory mechanisms that occur in a malignancy. Now, this is an important slide, so I'm just going to go through it in a bit of detail. The gut is not just a simple single bacterial infection. The gut has trillions of bacteria. And what's important to recognize is not only are there trillions of bacteria there and lots of food antigens, the blue line is the gut wall. That is a single cell thick. So there's only one cell that separates you from trillions of bacteria and food antigens. So in some respects, it's a miracle that we don't all have inflammatory bowel disease. And that is maintained because the immune system in the gut is set for tolerance and for managing the barrier effectively. So what you've got there is a thick layer of mucus, which is labeled, and into the mucus, the red dots are secreted antibacterial defensins, which punch holes in the bacteria that go into the mucus layer and destroy them. And there are immunoglobulins secreted into that layer, again, to keep it more sterile. And the junctions between the blue cells are very tight to not allow the barrier to be breached, except for things you want to absorb. And more than that, the immune system is very clever. That DC, that's a dendritic cell, that's an antigen-presenting cell. And they sit there in the gut, and they stick their little fingers, their dendrites, into the lumen, and they sample what is there. You can see one doing it there. And they sample it, and they say, this is okay, these are bacteria that are meant to be here, telling the immune system not to react and to maintain tolerance. And that is a really clever thing that the gut does, allowing that bacterial burden whilst maintaining that balance. Now, if that barrier is breached, different things happen. So if you get Campylobacter, because you haven't cooked your chicken properly, this will happen. The bacteria will breach, and you'll get immune activation. And this communication between the dendritic cell and the T cell, which is in purple, is critical to what happens next. Is that a short-lived episode of inflammation? Or, because of your underlying risk of inflammatory bowel disease, do you get persistent inflammation? And the dendritic cell tells the T cell what sort of immune reaction to undergo. And you'll hear a little bit more later about what's called a Th17 reaction. And that has been an important pathway identified in inflammatory bowel disease, critical to targeting with the new drugs that we've got. And finally, on this slide, you can see just at the bottom there that those cytokines also attract more white cells to the gut. So they're now coming from the blood cell, and they're accumulating in the gut to cause more inflammation. And that pathway has also been well described and is now targetable. So you're going to see these in action in a moment as we look at some of the drugs. It's important to say that what that shows is that we understand a lot about the immune reaction and how to target it. We're not yet very good, and you'll hear about that later, at manipulating the microbiome or other factors that might contribute to why people get inflammatory bowel disease. So, very briefly, who's at risk? Why don't we all get inflammatory bowel disease if it's such a difficult balance? And we don't know the answer to that, but we know that some people are at risk. Quite a lot of evidence now of genes being partly responsible for those who are at risk of inflammatory bowel disease. And there are now 240 risk locations in the genome that have been identified for inflammatory bowel disease. I'm not going to go into this in any detail, but it's important to understand that this has been a long journey from just recognizing that some families have a lot of IBD and that it runs in families, to really large genome-wide association studies that have identified this 240 genes so far. What's interesting is that this is an older slide, but there are many more genes than this now, but it represents graphically what I want to say, which is that, interestingly, although the diseases are quite distinct, as you've heard from Angie, UC and Crohn's disease look clinically distinct. Actually, a lot of the genes overlap, and that perhaps is partly the reason why many of the treatments that we have also overlap between the two conditions. So in purple are the genes that overlap between the two conditions, and in red are the Crohn's genes, and in blue are the ulcerative colitis genes. What's also quite interesting is that genetically, colonic Crohn's disease is as similar to ulcerative colitis as it is to small bowel Crohn's. So there seems to be a genetic ladder linking ulcerative colitis, which just affects the large bowel, colonic Crohn's disease, which affects the large bowel, and small bowel Crohn's, which affects the small bowel. And again, we don't need to go in this in detail, but the messages from inflammatory bowel disease genetics suggest that there are slightly different pathways activated for the different diseases, although in both, what I mentioned earlier, that Th17 pathway, which is now targetable, is activated or aberrant in both conditions. This slide is really just to remind me to say that having these genes is neither necessary or sufficient for you to get inflammatory bowel disease. And what's interesting is that they overlap with many other immune diseases, and that again reflects the fact that a lot of our treatments also overlap with diseases like rheumatoid arthritis and psoriasis. I'm not going to go into massive detail about the microbiome because you're going to have a talk about FMT, and I'm sure it will be talked about clearly then. But just to say that the gut is, as I've said, a very unusual environment. It's one of the most densely populated bacterial niches described. Very interestingly, when you're in your mother's tummy, your gut is sterile. It only starts to be colonized when you're born. And then when you're born, it's colonized initially by vaginal flora or by skin flora if you're born by cesarean section, and then gradually acquires the sort of adult signature around age 2 or 3. And various early life events can therefore affect how your microbiome originally develops. And how it develops and interacts with the immune system is apparently important, not just for inflammatory bowel disease, but for lots of other diseases. We've known for years and years that the microbiome appears to be important in inflammatory bowel disease, not least for an audience of many people that look after stoma, help patients look after stomas. We've known that bringing out a stoma and resting the bowel in Crohn's disease is a highly effective therapy, diverting that fecal stream away from the bowel, particularly the bacteria. Overall, again, this will be covered, I'm sure, later, there appears to be essentially a reduced diversity in the bacteria of patients with inflammatory bowel disease compared to those people without inflammatory bowel disease. Now, we don't yet know whether that's chicken or egg definitively. So is that already there and predisposes for you to get Crohn's disease and ulcerative colitis, or is it something that happens because you've got it and from the inflammation? There are some various overarching shifts that we can see. If you drill down into the data, there are apparently some pro-inflammatory bacteria like adherent invasive E. coli and some anti-inflammatory bacteria like F-Prau at the bottom there. And if you have more F-Prau after your operation for Crohn's disease, you're less likely to get recurrence. And if you have more AIEC, you're more likely to get recurrence, and so on and so forth. But we can't yet intervene directly on that knowledge for these bacteria. We've said this already, the gut's complex, there are lots of bacteria, there are lots of food antigens, and the immune system has a very difficult balancing act. And so in summary, this is where we've got to with inflammatory bowel disease etiology. We think there is a bit of genetics, there's something wrong with the bacteria, and possibly with diet. That leads to the immune system having an aberrant response, and the factors that we're less good on are the environmental factors. Angie's already mentioned that there's this funny dichotomy with smoking. Smoking's bad for Crohn's, it's protective for UC. That's the best described environmental factor. There are lots of others, but understanding them fully is difficult. Now you understand about how complex an area it is to work in the gut and understand it. We'll talk a bit about drug development. So here we are. We've got steroids and 5-ASA and thiopurines. These are old drugs. They've been around for decades and decades, still very useful. It took until the late 1990s to get anything new, and that was the first anti-TNF for Crohn's disease. That was when infliximab was first reported, and it's a beautiful case report. They've got this tiny, short, very skinny patient who is given this and suddenly grows and puts on weight and looks normal. It's an extraordinary case report. And then they were licensed, and these drugs are very useful. Along the way, before I get to what's happened more recently, in the intervening periods between 2005 and 2015, there were lots of failures. So I put this one up because I've already mentioned that Th17 is a really important pathway, and we know that from genetics and lots of other studies. And one of the key effector cytokines of the Th17 pathway is, funnily enough, IL-17. That's why it's called the Th17 pathway. So everyone assumed if you give an anti-IL-17 drug, you'll make inflammatory bowel disease better. And what happened? We made it worse. And that's on the graph at the bottom. So this drug, which works very well for ankylosing spondylitis and is given for that, and to a lesser extent for psoriasis, doesn't work in the gut. It actually makes inflammation worse. We can talk about at the end about why that might be, but it just is a demonstration of that difficult balancing act that the immune system has to go. So we had this huge gap where nothing really happened. And if you like, our competitor specialties like rheumatoid arthritis and psoriasis, they had loads and loads of treatments coming through, and we were very much the orphan disease area where we had nothing except anti-TNFs and older drugs. And then suddenly something changed. And in 2015, we got vedolizumab, and then we got ustekinumab, and then we got tofacitinib, all within the space of 5 years, which was absolutely fantastic for our patients. So how do these work? So I'm coming back to that little cartoon so you can kind of understand where I'm getting to. So this is the T cell, that inflammatory cell that we talked about earlier. And that makes cytokines, these important protein messengers of inflammation. So we know that TNF is important. We can already target that. We also know part of the Th17 pathway that targeting IL-23 is important. So we've got TNF inhibitors, infliximab and adalimumab, and we've got ustekinumab, which was that drug that came fairly late in the day, which targets both IL-12 and IL-23. And if you give those drugs, it blocks those cytokines and it reduces inflammation. How does that other newer drug work, tofacitinib? So here you've got signaling that goes through the cell. There are lots of pro-inflammatory signals where molecules interact with other molecules and cause inflammation or inflammatory proteins to be expressed. And this pathway is called the JAK-STAT pathway, and this was found to be important and is now targetable by a licensed JAK inhibitor for UC called tofacitinib. So if you block that interaction, then you block the production of cytokines. When you secrete cytokines and chemokines, which are related, that sends messages to the immune system to cause white cells, inflammatory cells in the bloodstream to slow down, attach to the blood vessel wall, and come into the tissues and accumulate, as we talked about earlier. And this perpetuates inflammation. And the interaction, you can see there's a little blue pentagon down there at the bottom. That interaction is a postcode. It's a postcodal address for the gut. That is expressed on the blood vessel wall in the gut, it's called MADCAM, and on the white cells is an address that goes with that postcode called alpha-4 beta-7. And this was worked out as a specific mechanism for the gut and is targetable by an anti-trafficking agent called vedolizumab. So that blocks that specific interaction. And therefore, over time, it prevents the accumulation of those cells and again, reduces the pro-inflammatory cytokines. There was a lot of anxiety about this drug when it was first produced because the first anti-trafficking agent was not specific to the gut, and when it's given to patients, it has a rare but serious side effect called PML, where the JC virus in the brain reactivates and you can get a very severe fatal neurological condition. So that sister drug called natalizumab is used in MS, progressive MS. In fact, it got a license for Crohn's disease in the US, but never in Europe. So a lot of anxiety about this drug, but it's proven to be one of our most safe drugs because of its gut-specific mechanism of action. So we give this to a lot of older patients and patients with cancer because we know that it's not causing the immune system in general to be suppressed. Before we go on to what's coming next, I'll just say a little word about those years from essentially the early 2000s all the way to 2015. So about 15 years where we had no new agents in IBD. We just had anti-TNF therapy and the other older drugs. Meant that in IBD, the community spent a lot of time working out how to use those drugs as effectively as we possibly could and get the most out of them. And that took a bit of time, interestingly. So they don't work for everybody. These drugs never do. But we worked out how to use them more effectively. So this is a slightly complicated slide. I'll just explain what it is. These are a number of different anti-TNF trials. And in the trials, on average, the patients had Crohn's disease for less or more amount of years on average. So the populations that went into the trial. So if you can see the step-up, top-down trial there, SUTD, the patients had a very short disease duration. And Accent, they had 7 or 8 years average duration before they went into the trial. And when you can see this analysis is that actually if you plot a rough curve, that actually there's an association between giving anti-TNF early in the disease course and overall response and remission rates to these drugs. So we worked out that if you give it early, you don't let the disease take hold, damage the gut. Actually, if someone's got serious enough disease to need these drugs, use them early. You get a better outcome. We also worked out, this is a beautiful study from Exeter, UK-wide study, which we took part in, where lots and lots of patients on the anti-TNF agents were monitored and their drug levels were monitored. And we'd known that loss of the drug in the body was a real problem for loss of response with these drugs for a while. And that's because your body recognizes these drugs as foreign proteins and destroys them. And this really highlighted that if you're on an immunomodulator like azathioprine, your body is much less likely to make those antibodies against infliximab and destroy it. So your persistence on the drug without antibody is that much better. Still bad, it's falling off, but these are the people without the drug. And the same, to a lesser extent, for adalimumab. So we now know that if you're on infliximab, at least initially, you should be on azathioprine, for example, or methotrexate. And we didn't know that definitively before. There's lots of other data. And even further than that, and this is going a bit technical, we now know that there's a gene that's involved in that association. So here are people that are on that immunomodulator and carry none of the genes that put you at risk of those anti-drug antibodies, which is what they're called. This black line are the people who are not on an immunomodulator and have 2 copies of the gene that puts you at risk of anti-drug antibody formation. And you can see that 100% of those lose response to infliximab. The drug disappears. So there's absolutely no point in giving these people the drug unless you're at least on azathioprine. So we worked out how to use the drugs that we had better. We still have a problem, which is, before I come to the new drugs that are coming, which is that the new drugs are fantastic and we're really very grateful to have them, as are our patients. But we're not yet in the era of personalized medicine. And often the way that we use these drugs is just through familiarity and the order in which they were licensed. So I'm going to give you a couple of case vignettes that highlight that. So here's a 56-year-old man with pan-ulcerative colitis. That means the whole of the large bowel is affected. He was diagnosed in 2015. As it happens, he also had latent Hep B, but that's, by the by. And he was given steroids and mesalazine. He was intolerant to azathioprine, so he was given methotrexate. Actually, we wouldn't do that now because new evidence shows that methotrexate is not a perfect drug in UC. We still use it in Crohn's disease. But anyway, he was put on methotrexate. And then he graduated onto infliximab. And he got secondary loss of response through antibody formation. despite being on methotrexate. So that's a good use of methotrexate there, trying to prevent those anti-drug antibodies coming. And he was given vedolizumab, and he had a primary non-response. And he was given adalimumab, and he had a primary non-response. And he went into a trial of a JAK inhibitor, and he had a primary non-response. What that says to me as a clinician is that this patient, unfortunately, is very unlikely to respond to medical therapy, because every treatment you get that having had not responded to one before, statistically you're less likely to respond to the next one. That's not zero chance, but your chance diminishes, probably highlighting that you've just got quite resistant disease. So he had active disease, he had a very elevated calprotectin, he had moderately active disease on a UCIS score, and really more in hope than expectation, we gave him the final drug that came off the rack in 2020, which was ustekinumab for UC, and we referred him again. He'd seen the surgeons before because we'd had conversations about the fact that he was likely to need a colectomy. Referred him again to Bruce George's clinic, saying, this is not going to work, but we'll give it a go. And of course it did work, and he's still on that drug and he's doing well. Which again highlights, I don't know if we'd given him ustekinumab at the beginning, whether this would all have been avoided. But I don't know that it wouldn't have been either, because we don't yet have predictive tools about who's going to respond to what. And that's the big challenge in IBD. Here's another example. This young man has awful small bowel disease. Not just at the end of the small bowel, not just a couple of segments, all the way through the small bowel. So much so that although he never had steroids, because I put him on top-down therapy at the very beginning, so infliximab and azathioprine, he ended up with osteoporosis, which is something I learned, that you need to think about this even when you're not giving steroids to young people who've got really bad small bowel disease. And basically, taking you through his case, he wasn't very good at taking his treatment always. He was doing okay, and then he stopped coming to clinic, and then he pitches up on neurology, with an awful headache and vomiting, and he actually had a really extensive clot in his brain veins because of severely active inflammatory bowel disease, a rare complication but recognized. And that convinced him that he probably should be taking his therapy. And he did okay for a bit on a different anti-TNF and back on azathioprine, but unfortunately not well enough. And Mr. George's case again, but he had to have initially just sort of life-saving surgery where he had quite a short stoma, so just 120 centimeters from the duodenal flexure to the stoma, and the rest of the strictures and problems with the bowel had to be just left to essentially cool off before they could be dealt with, and he went on to TPN. And when we looked up, this doesn't project very well, but you can see these nasty deep ulcers. This is looking up the stoma, so not even down at the bit that has to be dealt with later that's awful. He's got these nasty deep ulcers, which don't project very well, but you can see that one, I think, fairly clearly. Still got active disease. And we put him on, again, the only other drug that was available at that time that he hadn't had, vedolizumab. And we were really surprised these project better. This is the same place. That's the ulcer scar, completely healed up. Again, how do I predict that? I wouldn't have necessarily. He had really resistant disease. We were just, in a sense, lucky that we happened upon the right drug. And he did really well. Bruce took him back to theatre. He had the strictures downstream, strictureplasties, and he ended up having, after those multiple strictureplasties, the stoma reversed, and has actually remained well. And his most recent MRI showed no significant active inflammation. And what links these cases, as I've kind of already said, is that although we're really very grateful to have all of these wonderful new medicines to use, we don't yet know which medicine to use with which patient. So, to start to come towards the end now, what's coming next? So we've been really fortunate, and we remain very fortunate that the drug development continues. So just this month, filgotinib, which is a new JAK inhibitor, JAK1 inhibitor, has been approved by NICE for use in ulcerative colitis. We expect ozanimod, which I'll come to in a moment, about how that works, for a NICE approval probably later this year. And we've got other newer biologics that are going to more specifically target the IL-23 pathway. And not unimportant as well, in 2024, ustekinumab will be coming off patent, so it'll be much cheaper. So again, how do the new drugs work? Well, the anti-IL-23 drugs which most likely are going to be risankizumab and mirikizumab first. Again, they're anti-cytokines, they turn off cytokine production. We already have ustekinumab, which targets both IL-12 and IL-23. These drugs just target IL-23. And you might say, well, why is that an advantage, or why should it be, when one drug's targeting 2 pro-inflammatory cytokines, and this is only targeting 1? Well, actually, we don't yet know that it will be an advantage, but in psoriasis, it is, because you can see here the difference between the response in psoriasis between risankizumab, which just targets IL-23, and ustekinumab, which targets both IL-12 and IL-23, and there is a significant difference in the response rates. And we're hopeful, although it hasn't been proven, that being more specific in our targeting might be beneficial in inflammatory bowel disease too. You've already heard about the JAK inhibitors. We've got filgotinib that's literally just about to come into the clinic. We've got upadacitinib, which is going to come later. And again, just like tofacitinib, they prevent this pro-inflammatory cascade that leads to more cytokines. And we know that they work. That's the data in UC. And probably this will be slightly safer than tofacitinib, although again, that needs to be proven because it's a bit more targeted than tofacitinib. Other therapies that prevent drugs accumulating in the gut are on their way. One was trialed called etrolizumab, and unfortunately they probably misdesigned their trial, and that didn't meet its primary endpoint in UC, so it's unlikely to get a license. The Crohn's disease trials are still ongoing. But there is a related mechanism, not this one, where the lymphocytes come from the blood vessels, but a related one where lymphocytes, white cells, circulate back and forth from the lymph nodes, the local lymph nodes, and that mechanism has also been worked out, and you can block it with anti-S1P drugs. And these are on the way, and basically, again, prevent the accumulation of these white cells in the gut, again, leading to a loss of pro-inflammatory cytokines. These drugs definitely work. Again, there's the data in UC showing the difference between placebo and the drug. They're probably going to be less used than the JAK inhibitors because they've got a few more concerns about potential side effects, particularly in people who've already got eye and heart problems. I'm going to end with a case vignette again. So although I've talked about some of the problems that we are really benefiting, our patients are benefiting from the wider choice that we have available. So here's really an extraordinary case, an extreme case of very bad acute severe ulcerative colitis. So this is actually a 77-year-old. This is her first presentation, which just again tells you that these diseases are not diseases exclusively of the young. We're seeing elderly onset IBD all the time now. She has these awful, awful deep ulcers. A CRP of 350, which is the highest I've ever seen in ulcerative colitis, and very severe histological and endoscopic scores. And she got standard therapy, being very closely watched. I have to say, as her medic, I was advocating that we went straight to a colectomy, just so you're clear about where I was at. Because she was so unwell, I thought that delaying the colectomy at 77 would lead to significant complications and that the drugs almost certainly would not work and would just make her immunosuppressed and at risk of infection. So I was advocating for colectomy and the surgeon was advocating for medicine, just so you're clear. And actually, she did respond to cyclosporine. Along the way, she had a few bumps. As I predicted, she got a nasty pneumonia and was readmitted, and she had to be taken off the cyclosporine early. She did okay on that nice, safe drug I talked about earlier, the vedolizumab, which is gut-specific. But she didn't quite, again, this doesn't project, she didn't quite get into remission. And this is the importance of those targets I was talking about earlier that are changing. Although she was perfectly well in herself, and her CRP was 0.7, she still had quite a lot of active inflammation. You can see there just projecting a little, tiny little ulcer, much, much smaller than these horrible deep ones, but she wasn't quite right. And for various reasons, again, we felt that actually she was quite high risk for surgery for reasons that I haven't gone into. We then decided that we would give her tofacitinib, which had just become available. And again, although she had some bumps along the way, and when she went from the induction dose to the standard maintenance dose, she flared again and had to go back up to the induction dose, which carries some risks. She's done fantastically well. And again, I don't think this projects very well, but that is completely healed, that bowel. And she's still going now on this drug. And this is reflected, this is nice data put together by my colleague Jatsat Sanghi. So these are, in Oxford, cohorts of patients with acute severe colitis over the decades. So you can see the earliest decade is in the 1990s, and then in the blue on this side is the most recent cohort. And you can see that our use of rescue therapy over the decades has gradually gone up. And commensurate with that, the colectomy rate for acute severe colitis on that admission has gone from 30% to 15%. So it has halved. And that is maintained over the following year. So again, over the following year, the colectomy rate was 43%. It is now 21%. So we are making progress. How will we make further progress? Head-to-head studies telling us which of the medications are better head-to-head. And there are various different head-to-head ones that are on the way. In fact, I recruited someone to this study yesterday. We need biomarkers. That's really what it comes down to. This doesn't project very well. I'm sorry, something funny happens to this slide every time I put it up. This is a colleague in Oxford who's doing some really great work on biopsies, on gene expression profiles in biopsies related to specific histological profiles like ulcers and crypt abnormalities, and then is able to put those into distinct groups. And early data suggests that you might be able to use those groupings to predict who might respond to what therapy. So for example here, this red group are overexpressors of IL-1 beta, another pro-inflammatory cytokine. So they may be best given an anti-IL-1 blocker. This group, the blue group, are overexpressors of integrins. Those are the addresses that attract or allow the immune cells to come to the gut. And those, therefore, these patients might best respond to vedolizumab or an anti-trafficking agent. So this is early work, it's ongoing, but I think hopefully science will come to our rescue. We're going to get head-to-head data, we're going to get more treatments, we're going to use more combination therapy, as we've already heard, and I think biomarker science will eventually catch up. So in summary, IBD pathogenesis is complex. That's not surprising. The gut is a very complex environment. We are really fortunate, our patients, clinicians working in this area, to be living in what really is a golden age of drug discovery. We have to continue to apply those therapies in a more and more targeted, personalized way, and science really has to come to our rescue to allow us to do that, and I'm hopeful that it will. Thanks very much for listening.